We will now call upon Dr. Sudeep Das. He is a very senior phaco SICA surgeon, now mostly doing phaco. He is now back to Kerala and he is with us in Kottayam. And he will talk to us on zonules. What happens? Zonules are weak or broken. So this is one of the most dangerous situations which any phaco surgeon can face. Over to Dr. Sudeep.
Not back to Kerala, first time in Kerala.
Correct, not back to Kerala.
So this is of course a very old video, that's why the quality is like this. It's the strangest zonal dialysis I've had. So basically what we are taught when you do a hydrodissection, we go and inject on one side, and then when we come to the opposite pole, we depress the nucleus and we move it towards the original site. Okay, and here the patient also decides to, so I go in, I do my hydrodissection, then I come to the opposite side, and the patient decides to help me by lifting his head. And the zonules on that side go down. So anyway, so I just put in a CTR and finished the surgery. Fortunately, the rest of the zonules are all right. This was another one where I was called in at this stage. This was a fellow surgery. So very senior fellow, almost at the end. And then he had a zonal dialysis. The vitreous was there at that point. So this is where I take over. Unfortunately, the previous part wasn't recorded. So I decided to put in these iris hooks, and if you see, the iris hooks are going quite scleral. So they're not tenting up the iris at all. They are at the level of the iris. And then so 3 of them here. The rest of the zonules seem to be all right, and it's a very black cataract. And of course, you cannot do anything without doing an anterior vitrectomy. This was in the olden days where the vitrector was 20G. So once it's done and the capsule is supported by the hooks, I can sort of proceed and complete the phaco, do a direct chop and complete the phaco. I could have possibly used more hooks to just dilate the pupil a bit more, use some 3 more or 2 more hooks. Ideally, I should have, but then it went on well. So basically, the zonules are not there. The hooks are supporting the back. The hooks are taking the place of the zonules. And of course, you have to use a lot of viscode because here you tend to work a little more anteriorly. And at this stage, because part of the nucleus is gone, the support is not there, the equatorial support. So I decided to put in the CTR, and this video is also speeded up. And I usually use the micro-rhexis forceps instead of a dialer to insert the last bit. And now, of course, the bag is completely stable. It's not just supported, the equator is also stretched out. In the brown cataract, initially when you start, till you remove a few pieces, the bag will remain stretched because it's such a big and heavy nucleus. But once some of the pieces are out, you need to put in a CTR. Otherwise, it's not just the edge which is supported, the rhexis. The equatorial part will start coming out. Well, this supports that. So once that is done, and I have a CTR in place, I can put in any IOL of my choice into the bag, and then remove that. And of course, you have to check again whether there is vitreous. This was another strange case. It was a hypomature cataract. And when I injected, that's when I started recording. When I injected blue, I realized that part of it wasn't staining. Till the time, there was no suspicion that it was slightly subluxated. It hadn't been seen in the OPD. And it's a white cataract, very difficult to see. So before I do anything, I do a vitrectomy there. And I haven't even done my rhexis or anything at this stage. So you have to have your eyes peeled out. I mean, if you think that, you don't notice that, then you'll end up in a real disaster. If you don't realize that why the capsule is not staining is because of vitreous. And you can see the capsule is pretty mobile. When I'm doing the rhexis, the whole capsule seems to be moving because a lot of these hypomature cataracts, the nucleus and everything shrinks down, and the zonules are also not very great. and then of course the CTR goes in, and I'm inserting it to the side of the ZD, suspected ZD first, because I'm hoping that the rest of the zonules are better than this side. So always inject, expand the side which has the zonular dialysis first. And then, of course, the cataract is not a very hard cataract, and it really, there's nothing very different from this stage. But you have to be gentle. If you see, I'm not really stretching it much. Normally, I would stretch the nucleus a lot more. But here, I'm trying not to stretch because that itself will put some pressure on the zonules. And this is, as you can see, it's a really leathery cataract. And I've got a split. This is again a long chopper. And so I'm using viscoat. And after I finished, I suddenly realized, what is that piece doing there? And you saw the surgery also, there really wasn't anything to show that there was a zonular dialysis. And look at the amount of, the size of the piece which has gone in. And again, that area just closes. There's no vitreous, there's nothing there. And you had these enormous two pieces which were there, which had gone through a subincisional ZD and were in the sort of just, and I think I removed everything, but again I see a shadow there, so I go in with visco, and again go through the equator, and there's another piece. And you see the ZD is not really very large, but somehow, and normally we have eyes on what's happening, and somehow I missed these pieces going behind completely. So I put in the IOL and then for safety, and then remove this piece. So I don't know whether there was a pre-existing weakness there, because where I would expect the least manipulation is, and I haven't sort of pressed down the nucleus at all at any time at that point. And sometimes what happens when we have cataracts like these, we finish the nucleus management, and then there's like a, we relax, and that's when we catch. So I've caught the capsule there. So since I didn't have a CTR immediately, they're getting the CTR, I thought, okay, let me put the IOL and that will expand the back. Unfortunately, the haptics didn't, plans don't go according to what you think they will. So I thought the haptic will expand the back, but the haptic didn't open at all. They're like doing a handshake, and they're stuck there. So then anyway, by the time the CTR came, I inserted the CTR, I released the haptic and the cortex. So take-home message is that you have all the tools needed to handle whatever emergencies you have during surgery. And the ZD can happen at any stage of surgery, like I showed you. And watch out for subtle signs of ZD. So you have to have the CTR, hooks, iris or capsule. Capsule is theoretically better, but I somehow prefer the iris hooks. Have dispersive OVDs, viscoat or any of the Indian substitutes. And you have to have always in the OT have a working vitrectomy cutter and a range of 3-piece IOLs and the presence of mind. Thank you.
Thank you, Dr. Sudeep. He is a very cool surgeon who manages difficult situations, difficult challenging situations very coolly. I have seen him do, and I used to wonder how he can be so cool when they have this. So